Good morning. Thank you all for joining us today to hear the latest from our medical experts on this rapidly evolving pandemic. Dr. Graham Snyder, our Medical Director of Infection Prevention and Hospital Epidemiology, will first update us on UPMC's testing efforts, both our patient diagnostic testing and our community surveillance research testing. Dr. Don Yealy, our Chair of Emergency Medicine, will discuss our ongoing preparedness efforts and the rapid expansion of our telemedicine capabilities. And finally, Dr. Rachel Sakrowitz, Chief Medical Officer of the UPMC ICU Service Center, will explain UPMC's in-hospital and ICU preparations and the way our telemedicine strengths are being leveraged across the system so that specialists in one region can assist hospitals in other areas. After they give a few brief remarks, we will take your questions. Dr. Snyder.
Since I spoke with you a week ago, we have continued to expand the use of our UPMC diagnostic test. Physicians have the ability to order this test for their patients based on the patient's symptoms and in the context of their potential exposure to their virus. These tests are being performed in the UPMC laboratories and commercial labs and our public health partners, and specimens can now be collected at 5 different sites throughout the Commonwealth. Across the UPMC system, we have performed 1,743 tests, and 141 have been positive. That's a positive rate of 8%. I'll also update you on the community surveillance research testing that Dr. John Williams has described to you in previous press briefings. This is the testing that is done in people with cold or flu-like symptoms that prompted them to seek care at a UPMC facility. Out of nearly 2,000 tests performed in this community surveillance study from January through this Thursday, 9 have been positive, all in March. That's a positive rate well below 1%. Combined, the data from these 2 testing methods show us that COVID-19 is here, but not necessarily as intensely active or widespread as other regions of the country. What this means is that we and public health authorities still find value in identifying and tracing positive cases. That can help us stem the spread. Whenever we detect a case in a healthcare worker, patient, or any person who had contact with any of our facilities, we launch a full case investigation to try to determine how they contracted the virus and any exposures within our facilities that may have occurred as a result. We collaborate with our public health partners so they can do similar contact tracing outside our walls. The relatively low prevalence we're seeing in our communities also tells us that we can still safely perform medically necessary procedures now that cannot be delayed for months. If you require medical attention, UPMC is here for you. And finally, it tells us that all of our efforts at social distancing have value and should be continued until we have data telling us otherwise. Among those efforts is an exponential growth in our video visits, which allow us for UPMC clinicians to provide the high-quality care our communities expect without our patients or clinicians risking any exposure. Now, Dr. Yealy will tell you more about how UPMC is responding from a care perspective.
Thank you, Dr. Snyder, and I want to thank everyone who's participating, particularly those who are doing at a distance and following the guidelines that we know will help us get through this pandemic. What I've relearned in the past few months as we've prepared for this unprecedented pandemic is that UPMC partners and staff don't say no. They don't say I can't do it, and they don't say that's impossible. Our teams have all kinds of people. They're dedicated, they're proactive, they share innovative problem solving, they give us feedback on ways that we can provide the best care for our patients and do it safely. The people we work with at UPMC, especially those that are involved with patient care and the support of patient care, are making tremendous personal sacrifices, as are their families. This is what caregivers do. I thank each one, and I know the UPMC leadership and I are thankful and honored to work with such a large and dedicated team. On top of this, the entire community thanks you, and our care and our support partners at UPMC recognize this gratitude. One of our major achievements in the past few weeks is a phenomenal increase in our video visit capabilities. This allows for safe, ongoing care, or even new care, for many different needs. Patients who have a new need for care, those who have a chronic condition that needs more assessment or more care, post-acute care follow-up and visits, and even mental health aid. We can serve our patients and our partners well using this advanced video capability. Some of the details are, over the past 2 days last week, we did as many telemedicine visits, that is video visits, across the system as we did in the entire year of 2019. We have convenient video visit options and capabilities no matter what you need, for urgent care or not urgent care, but necessary care. In addition to allowing safe care for all, both safe for patients and for our providers, the video visit allows us to be more ready with protective equipment when COVID-19 infected patients need care at the hospital. Patients who are hesitant to come in person for their appointments can do a video visit with their primary care provider or their specialist. Thousands of these people are now enabled to do these video visits through many different applications, including My UPMC. That's available on your phone or online. We're now doing more urgent visits through UPMC Anywhere Care. We do more of these visits now than we do in our urgent care settings. If something arises, this option's available to you. And it was available prior to COVID-19. It's being used at a dramatically increased pace now. We have seen a 5-fold increase in demand and have added or redeployed physicians and other experts, including advanced practice providers, to meet this need. UPMC was ready well in advance, and we adapted very quickly to this rapid increase in demand. Our multi-billion-dollar investment in technology, infrastructure, and people in the recent years made all of this possible. I thank our dedicated informatics staff who recently have been able to bring us up to speed quickly and done so without any hiccups. UPMC is here to serve you in person, online, no matter what your need is. Regarding the COVID-19 experience at UPMC, let me update some of the details right now. As of this morning, UPMC currently has 25 inpatients that are positive for the COVID-19 illness throughout all of our hospitals. That's 5,500 total beds across the entire system in a 40-hospital system. We have more beds available to provide acute care for patients than we've had in recent times in the past year. We are preparing for a surge that we hope never arrives, but we're ready for the worst. We're also ready for all other kinds of health care that's needed separate from COVID-19, notably emergency and other needed care. We will continue to serve our community and will do it safely. We have adequate supplies of all the protective equipment that's necessary, starting with masks, including both surgical masks and N95s. We have gowns and gloves available. We carefully educate and deploy these tools to make sure that we're ready to safely give care today and in the future. We learned and saw the experiences elsewhere, where different types of preparation ahead of need and different deployment threaten basic protection. We learn from others. Being smart now is critical to our ability to provide care later. Because of this careful approach, some believe that we are short on supplies. Let me reemphasize, we are not short on protective supplies. Any employee who can't find the protective equipment they want immediately has the ability to talk to a supervisor and get the equipment that's necessary. There is no need for anyone to provide care without the proper equipment. Another adaptation to our local experiences is our new policy where all staff and visitors to our hospitals are screened for COVID-19 symptoms and exposure and given a surgical mask. This means that starting yesterday, every staff member and every visitor who is working at UPMC or coming to UPMC will be screened and have a mask for protection. Finally, the community response has been amazing. We get hundreds of people and organizations offering help or seeking to donate supplies. Some offer to bring food for our hardworking staff. We're grateful and we're encouraged by the outpouring of support from the community. This is Pittsburgh. This is Western Pennsylvania. Good people and good neighbors. To tell you more about how else we're prepared within our hospitals, I introduce Dr. Rachel Sakowitz.
Thank you, Don. One of the advantages that UPMC has in facing this pandemic is that we are a large system spread across a very broad geography. This gives us the ability to confront this challenge as a 5,500 bed system, not as individual standalone hospitals. Our goal is to put structures and processes in place that enable us to leverage the full capacity and capability of our health system to meet the needs of our patients. If one region in our system ends up getting hit hard, we can safely transfer patients, with or without COVID-19, to hospitals in our system that are under less stress. In addition to being able to balance patient census across hospitals, we have also put a system into place to enable us to redirect staff and supplies to the parts of our system that need them the most. This isn't just about frontline healthcare workers. I'm also talking about maintenance workers, administrators, IT support, and professionals. We are flexible enough to fulfill most any need at any of our hospitals at any time. We're tracking and measuring everything: available beds, locations of ventilators, staff availability, and have created a dashboard that allows us to activate our surge plans in response to the availability of resources and demand for services across the system. We're also extremely fortunate to have fantastic partners in the community that have offered to help us respond. For example, the University of Pittsburgh has opened one of its empty dorms to our hospital employees so they can have the comfort of a place to stay nearby when working back-to-back shifts. But we don't have to rely exclusively on physical travel to support the varied needs across our health system. You heard Dr. Yealy describe the exponential growth in video visits for patients. We also have telemedicine capacities and capabilities to care for our inpatients. We're using telemedicine to support our bedside teams with virtual teams so that a specialist at one hospital, say a critical care doctor here at UPMC Montefiore, can work with a clinician at a hospital all the way across the state in Susquehanna to provide care to ICU patients there. This tele-ICU model removes barriers to providing the highest level of critical care to more patients. We also have created a telemedicine-enabled infectious disease consultation company called ID Connect. This spinoff was developed by our infectious disease doctors and funded through UPMC Enterprises. By Monday, ID Connect will have a call center set up to help all of our hospitals during this pandemic with physician-to-physician infectious disease consultations for inpatients. The focus, of course, is on COVID-19, but these specialists are available to help with any infectious disease needs. And this will avoid unnecessary patient transfers and also offered much-needed support and backup to our bedside infectious disease physicians. I'd like to talk a little bit about personal protective equipment, or PPE. Within our hospitals, much of our work so far has revolved around ensuring the careful utilization of our supply of personal protective equipment. Our masks, goggles, face shields, gowns, and gloves, so that we are able to protect our staff now and for the work ahead. We're developing special teams in the emergency departments, the ICUs, the operating rooms, to perform procedures that have a high risk of aerosolized exposure to the virus. These teams will respond quickly and safely using full protective equipment. These teams will help us minimize the number of people involved when high-risk procedures are needed and allow us to be sure that these teams are highly trained, both in the procedure at hand and also in the use of the high-level protective equipment. In every hospital, we'll have staff available 24/7 to respond just in time to supply our healthcare workers with protective equipment when needed. Preparing for a once-in-a-lifetime pandemic is a massive and humbling challenge. I know I speak for all of my amazing colleagues. We are fully committed, hearts and minds, to the work ahead. Nobody can be truly ready for this, but we're as prepared as we can be.
Thank you, doctors. And now we'll take questions from the media, all of whom are joining us remotely online from across Pennsylvania, Maryland, New York, and Ohio. To ask a question, you'll need to go to the bottom of the participant's icon at the bottom of your screen and then press the Raise Your Hand button on the pop-up window that follows. That will put you in the queue. If your question has been asked and answered and you want to remove yourself from the queue, you can press the Lower Your Hand button. We will try to call on as many different media outlets as we can in the time we have allotted. And I will first read your name, and your line will be unmuted for you to ask your question. The first question comes from Todd Bartley at WEJS. Todd, go ahead.
Thank you. Dr. Snyder, of the 141 positive cases that you've identified so far and the 25 that are in hospital, how many total have been in hospital of the 141? And also, how many have recovered?
So we have, of the 141, we currently have 25 who have been hospitalized. They're in varying levels of care, from relatively mild illness and being hospitalized to intensive care unit care. And some have been dispositioned home at this time. So that number will continue to fluctuate, including day by day.
Okay. Thank you, Doctor. Next question comes from Megan Guza of the Pittsburgh Tribune Review.
Hi, how many ICU beds does the healthcare system have across all of its hospitals? And are there any talks to perhaps turn to ambulatory surgical centers or other non-traditional places to create more bed space?
Thank you for that. That's a very good question. We currently have 750 ICU beds across our system. And additionally, we have another about 450 beds that we could convert from intermediate care unit beds to ICU beds should we need to. That is a tremendous ability to flex up in a very short period of time to cover about 1,500 critical care patients. But in addition to that, every hospital in our system is creating a plan to take care of as much as 200% of their capacity. And part of that planning involves looking around and preparing spaces that aren't currently used for patient care or ICU care to meet that need going forward. So I think that we have a lot of space to take care of the critical care needs ahead.
Thank you, Doctor. Next question, Sean Hamill, Pittsburgh Post-Gazette. Sean, go ahead.
Dr. Yulee and Dr. Snyder, you both made reference to continuing to do care that was necessary, but since last weekend, doctors and nurses tell us that there was a dramatic shift in the elective surgeries. The cosmetic surgery division was shut down, I believe, on Wednesday. Outpatient therapy, I'm told, was drastically reduced. What changed since last weekend that led to these changes? Was it the complaints from the nurses and doctors, including the letter with 300 residents signing on saying that they wanted you to make changes? Was it the coverage in the press? Because it seemed a dramatic change from the last time we talked last Friday.
Thanks very much for that question. I think, as you've recognized over the past few weeks, our approach at UPMC to handling the COVID-19 epidemic is based on not only what we're experiencing here, but what we expect to experience. And we use the data that are available here plus the experiences of other people. So it's natural that our approach to how it is we provide care is based in part on our regional experience. Secondly, we're completely aligned and compliant with any governmental guidance or mandates about care, and we follow those completely. That actually is what drove our decision-making and our actions about how it is we do care that's scheduled. Not all care that's scheduled is unnecessary, and we've developed a careful plan to help make sure that those who need care continue to get it.
For the complexity of this epidemic, and the constant evolution, we're going to continue to see an evolution in our approaches to providing care so that we can continue to provide the care that's necessary and do so safely. And so instead of a dramatic approach, we're actually making continual changes. I'll also add that Hearing from healthcare workers, patients, and visitors in our system is incredibly important to us. We have had an unprecedented number of bi-directional community conversations with our healthcare community, particularly with providers, doctors, advanced practice providers, nurses, and for others, in either focal groups or broadly. In fact, Dr. Yealy and I have already done a couple last night and this morning that set records for the number of participants. These are welcome opportunities to hear concerns, to share our vision for how we respond and how we're keeping healthcare workers and patients safe.
Okay. Thank you, Doctor. Again, to ask a question, go to the bottom of your page and press on the participants icon, and then press the raise your hand button on the pop-up screen. That will put you in the queue. Next question comes from Paul Goff, Pittsburgh Business Times. Paul, go ahead.
Thank you, Paul. What's the plan? You talked a little bit about this, but what's the plan moving forward for care like on chemotherapy, radiation therapy, maternity care, the kind of stuff that needs to be done regardless of whether there's a pandemic or not? So how will that change in a potential surge? You talked a little bit about how, different hospitals might have different things, care available, but, the non-COVID-19 care, how will that be carried out both at the hospitals and also cancer centers, physician practices, that sort of thing? What's the plan for that? And thank you very much for the briefing.
Thank you for the question. And I think, again, what it requires is a careful plan that weighs the patient's needs, the individual physician's decision about how treatment can affect both the short-term and the longer-term outcome, and guidance from experts locally. And we have those plans available for all those populations. Not all care that is scheduled is unnecessary, and you hit on some important areas. I don't think pregnancy care or cancer care would be perceived as elective and unneeded. It's important. We want to leverage not only the physical opportunities, but some of the virtual opportunities that allow us to stay in contact with our patients at a distance using video technology. I think we'll be able to continue to serve these needs, and I think our actions up until this point show the UPMC commitment to taking care of what's needed for our patients in our community.
Thank you, Dr. Yealy. Rich Lord from Public Source. Rich, go ahead.
Thank you so much. There's understandable concern about the potential impact of this virus on health system staffing. Can you tell us how many UPMC employees have tested positive for COVID-19 and in which hospitals, and how many have been told to quarantine because of potential exposure?
We're, of course, as we've mentioned in previous press conferences, interested in protecting the privacy of both healthcare workers and patients in our system. So I won't be disclosing the number of healthcare workers that have been tested or where they are. I will say, again, that our healthcare workers may be tested for a variety of reasons. They may be tested because of a community exposure. They may be tested because of potential exposure in our hospital setting. We work with our employee health colleagues. Infection prevention works with our employee health colleagues in the system to trace any potential exposures and give the right guidance to both patients and healthcare workers on how to keep themselves and their families safe. That's a responsibility that, from a public health perspective, we take very, very seriously and try to investigate to the full extent that we can in partnership with our public health colleagues.
Okay. Thank you. Next question comes from Harrisburg. David Winter with Penn Live. David?
Thank you. We in the news media, reporters in the UPMC communities where we have UPMC hospitals, we are hearing from doctors and nurses who describe a shortage of protective equipment and supplies, and but they also tell us they're not allowed to talk on the record. My question is, why is UPMC barring its doctors and nurses from talking about these things on the record, and what is the penalty if they do?
Thank you very much for that question. I think, simply put, UPMC is not barring anyone from having any type of contact. What we do expect is that anyone who's involved with healthcare is careful about sharing any patient-related, protected private information. But we certainly do not inhibit or bar or penalize any other conversations. That's evidenced by you've had those conversations already. We also look for that kind of feedback inside UPMC to make sure that we not only understand what our partners that are providing care are experiencing right now, but to hone our approaches to it. So many people may have perceptions of difficulties with protective equipment, for example. We try to identify where that concern is and fix it promptly.
Okay. Next question, Paul Van Osdel, WTAE TV. Paul?
Yes, thank you. I wonder if you could address if the percentage of patients who are currently in the ICU units who are suspected or positive of having COVID-19. Also, if you could discuss the difficulties, if any, you're having staffing ICU units, especially with nurses, in order to treat COVID patients.
So we right now have 17 patients in our intensive care units. And any patients, any physician that has ordered a test, suspects COVID-19 can order a test and diagnose their patients. That obviously is something that is fluctuating day by day and even minute by minute as doctors assess new patients and reassess their patients that are in the hospital. I will add that the number of ICU beds is an important measure. We essentially can think about this epidemic in terms of a pyramid where at the bottom of the pyramid are asymptomatically infected individuals, and those, of course, we can't identify. We also have patients who have mild illness who remain in the community. We have people with mild illness who present to care, that gives us an opportunity to diagnose and test them. We also have individuals who are ill enough to have to be hospitalized, and individuals that are ill enough to require an intensive care unit. We take a data-driven approach to responding to this epidemic and recognize the limitations of the data that we have in that pyramid. So for example, we can't know asymptomatically infected individuals because they don't present to care and it's not appropriate to test asymptomatic individuals. We also are subject to, early in the epidemic, some limitations in specimen collection and testing capabilities. So we had to test people who were most likely to have COVID-19. Now that we have dramatically increased our specimen collection and testing capabilities, we are of course seeing a larger case count. In other words, a larger number of people. That's because we're doing more aggressive case finding. One of the key indicators for us is the number of people who present in an ICU, who require ICU care, who are diagnosed with COVID-19. This is a number that is less subject to bias because we have, those patients have to present to care essentially. And so we use all of that data, plus the community studies I mentioned before by Dr. Williams, to get an understanding of the extent of the epidemic in our communities, and therefore take a targeted approach to improving the situation.
Yeah, I mean, to add to that, I would say that currently we are very well staffed from a nursing perspective and from a full healthcare team perspective. It's been amazing how our team has responded. You know, everyone has volunteered to do more, to do extra, to do what needs to be done. But in anticipation of things changing moving forward, we have plans in place to bring in team members from other areas that could support patients in the ICU. In particular, we've built a 24/7 tele-ICU model where a virtual intensivist could support about 100 ICU patients, leveraging a multidisciplinary team at the bedside. So we're prepared to take care of our patients now and in the future.
Thank you. Our next question comes from Michelle Ganassi of the Somerset Daily American. Michelle? Michelle, go ahead. Okay, again, if you have a question, go to the participants icon at the bottom of the page and press on the raise your hand button. That'll put you in the queue and I'll be able to unmute your microphone. Next question, Liz Reed from WESA FM. Liz?
Yes. To prepare for a surge of COVID patients, UPMC says it's decreased the number of elective surgeries it's performing. Can you quantify that decrease? Is it a 50% decrease, a 90%, something else?
So all of our ambulatory surgical centers are closed, and the inpatient, that is the hospital-based surgical procedures, are down about 60%. That's because of patient decisions, that's because of individual physician decisions, as well as our efforts to fully comply with the requirements and the responsibility we have to both our providers and to our patients.
Thank you. We have a question emailed into us from Bill Kibler at the Altoona Mirror. If you have a COVID patient at home, what is life like for that family? What should be done at home? What should be done to clean the house? Dr. Graham?
So we have public health guidance on taking care of individual, or taking care of self-care, or taking care of a family member with COVID-19 at home. Several aspects of maintaining being safe. In some situations, those people in that home may choose to socially distance, either if the opportunity presents, live in a different setting for the period of that illness in order not to transmit the disease. If that's not feasible, there is some social distancing that can be done within the house. Some of that involves maybe separating family members in different rooms. It's key, even if you can't do that, to be conscientious about what you share in that home and setting. For example, avoiding sharing utensils, glasses, towels. Additionally, cleaning surfaces is important. These are the high-touch surfaces, and the organism does not require any special cleaning products. If you have a household cleaner that says something like kills 99.9% of viruses and bacteria, that's great, it will do the job. And then, of course, wash your hands and respiratory etiquette. This is cough or sneeze into a tissue or into your elbow. Those are the types of things that can keep a family safe. Last thing I'll say is that if you're at home with COVID-19, your public health authorities will know about you and will give you some advice about keeping the family safe, so they are a very good resource for you. And additionally, will give you advice about when you can return to your usual activities.
One thing to add, when you're washing your hands, simple soap and water still works best. Use that. You can't overdo it.
Thank you. Next question, Jamie Martinez from the Tribune Review. Jamie, go ahead.
Based on the surveillance, the community surveillance data that you've been taking and analyzing, can you give us a sense of what localities or cities are most similar to the Pittsburgh region? I mean, we're seeing news come out of cities like New York, but what are some areas that are similar to what we're seeing here?
Yeah, Dr. Williams' data comes from a community-wide sampling, and I'm not sure that I see any particular trends, especially since the number of positives are so small, only 9 out of 2,000. It's a pretty small number to try to parse out any geographic patterns. I would refer you, though, to the Pennsylvania DOH website, where you can see activity by county level. And it's pretty much, I think, what we would expect. Where there is a denser population of individuals, we're more likely to see transmission. That actually can be extrapolated to what we see around the country. One of the major factors in transmission and the level of activity for this organism is the degree of social contact. So in a place like New York City, where there's extensive amounts of social networks, where there's a high degree of interpersonal contact, it's not surprising to see that's a hot spot in the country. And in Pittsburgh, we're less densely populated. It is not at all surprising that our epidemiologic curve is a little later than New York's. And the hope is that the targeted public health interventions that are being put into place can flatten the curve, and since we've done those interventions early in the curve, we will hopefully see a different epidemic profile than they're seeing in New York.
Let me add one other thing. Your question was, how does this background information compare with background information in other communities? One of the advantages that we have here with a world-class, not only university, but world-class academic medical center, is that we have this type of background research. Most other locations simply don't know the answer to this question, therefore we can't compare to it. Dr. Williams' work is novel, it's insightful not only for his personal research, but it helps us understand our community.
Okay. Thank you, Doctor. Next question comes from Brett Schulteis at WITF Radio. Brent?
Yeah, Yes, good morning and thank you. And I'm a reporter in Harrisburg, so I'm focusing mostly on Harrisburg and also Lancaster County, where the Harvard Global Health Study has shown that there could be 2.5 to 7 times the number of ICU beds that are available statewide, and particularly in York County and in Lancaster, there's a lot of need. So I want to ask specifically, what are the plans there, and specifically how many ICU beds and ventilators are you working to add right now? I know some doctors have wanted to do things like reopen the shuttered UPMC hospital in Lancaster, and I'm just wondering if any of those plans are in play as well, but specifically focusing on the number of beds, ventilators, specific things.
Well, as I had mentioned before, we at baseline have a very robust number of ICU beds and the ability to flex quickly to nearly double our ICU beds. And again, your question was pertaining to a particular area in our system, but I think when we look at this, we think about our system as a whole. So in addition to those beds I mentioned, there are other areas where we could quickly add beds in any hospital. For example, PACUs, places where patients normally recover from surgery. Units that are usually for non-critical care patients can be transformed. Areas that are designed as triage areas could be where patients stay for a longer period of time. So I feel very good about that and our capacity as a system to rapidly flex up. We're also looking at, to your point, other sites that are not currently delivering patient care outside the walls of our hospitals. For example, hospitals that are in existence but not active, or repurposing other spaces. For example, the University of Pittsburgh has offered up some of its spaces that could be quickly transformed into patient care units. So I think we are in good shape as a system, and we'll meet the needs of any of our regions with the resources that we have.
Thank you. Again, if anybody has not asked a question, go to the participants icon at the bottom of the page and press the raise your hand button, and that'll put you in the queue. We have a follow-up question from David Winter at Penn Live. David.
Thanks again. This has to do with the community surveillance. I'm assuming that's actually confined to the Pittsburgh region. And my question is are you planning to extend that kind of surveillance to any other communities, such as the Harrisburg, Lancaster, York community that I'm in? And if you don't have that kind of data from those communities, how does that affect your decision-making regarding things like supplies and elective surgeries? I mean, does it put you at any disadvantage in those communities, such as Harrisburg, York, and Lancaster?
So the data comes from an existing study infrastructure, and so from a UPMC perspective, we're not at liberty necessarily to extend that research infrastructure since it's part of that infrastructure. It is focused on Western Pennsylvania, but that's not the only piece of data that we're using. And so we use publicly available data from our colleagues in public health. We use our own UPMC testing data from all 5 specimen collection facilities and the where patients currently live. And in addition, we use our hospitalization and intensive care unit data. All of that data gets packaged together in our decision-making about where to deploy our resources and how to anticipate needs as the epidemic evolves.
Thank you. Next question is from Carrie Pauling of North Central Pennsylvania Business Times. Carrie, go ahead.
Hi, thank you. UPMC Sunbury is in the process of closing for good, supposed to be closed by March 31st. Has the COVID-19 pandemic affected that closure? Is that on hold? Are you reviving any services there?
I think our plans are to see how the situation evolves and then to make decisions in a timely fashion so that we can reopen or expand into new areas. Right now, we're really at the beginning, and our planning involves having enough lead time to be responsive to the number of patients that we need to care for.
Our final question comes from Danielle Fitzgerald of the Beaver County Times. Danielle?
Hi, thanks. So I have a question about testing. I spoke with a physician who was saying that the best environment is to test in a negative pressure facility. So what would you say about drive-through testing? Is that not necessarily a good way to go? Is that something you guys are thinking about doing, or is that really maybe not the best thing?
One of my top priorities is protecting healthcare workers. So when performing the swab, the nasopharyngeal swab, as many people who have done it or had it performed know that it's hard not to cough or sneeze when that happens. And so that's the potential to transmit infection in that moment. So how do we protect healthcare workers in that moment? The most important thing is to put healthcare workers in the appropriate personal protective equipment to minimize the risk of exposure as much as possible. And we do that anywhere that we're doing specimen collection. Engineering controls, including negative pressure isolation rooms, aren't necessarily needed to do that safely. It depends on the care setting. Now, whether you talk about open air testing or the type of testing, for example, we have set up in Southside, the specimen collection, I think whether you decide to structure it in either of those ways is almost immaterial, as long as the healthcare worker is safe. Now, we have chosen to start with our Southside specimen collection facility. We were very conscientious about the engineering controls and personal protective equipment, so we made sure that none of our healthcare workers were exposed. And that is a high volume facility. We're cranking out hundreds of specimens a day. It's been very productive, and it's been extremely, extremely well received by the patients that have been there and the healthcare workers that are working there. As we expand, we'll continue to look at any appropriate opportunities to expand specimen collection so that we can test everybody that needs to be tested.
One other important thing to consider with essentially outdoor testing is spring in Western Pennsylvania sometimes looks a lot like winter in Western Pennsylvania. And an outdoor testing facility like that, drive-through or not, will be subject to all of those realities. And so we chose fixed facilities. They're now available throughout the UPMC system. It's not that we wouldn't consider others, but we've expanded safely our testing options using more practical and less prone to weather issue kind of testing opportunities.
Okay, thank you. And that concludes the time we have allotted. Thank you all for participating in our virtual press conference. We plan to continue holding these regular updates for the media as long as there is a need. In the meantime, reporters with questions are encouraged to contact our UPMC Media Relations Department at upmc.com/media. Please follow @UPMC News on Twitter for updates. Thank you.